I have no relevant financial disclosures to make. I want to thank the organizers, the Committee on Education of ASBMT, in conjunction with the Special Interest Group, inviting me to speak today. So this is really the catchiest title, I think, of the entire session, Phases of Transplant Follow-Up. I think that as you go through, I hope that you understand that thinking about the phases of transplant follow-up actually began before transplant. So let's get started. This is case 1. Ashley is a 16-year-old high school sophomore and a star soccer player for her team. She was diagnosed in 2012 with stage 2A Hodgkin's lymphoma. She entered into remission following ABVD and mediastinal radiation, but she relapsed 9 months later. So Ashley is responding to salvage therapy and is going to undergo an autologous peripheral blood stem cell transplant. And she and her parents meet with you to discuss what they can expect post-transplant. This is case 2. Mrs. Baker is a 33-year-old trial attorney. She is in her first remission following idarubicin and cytarabine for high-risk AML. She's NPM1 wild type. She's FLT3 positive. And she's preparing for a sibling-matched peripheral blood stem cell transplant. She has 2 sons, ages 4 and 1. And she and her husband meet with you to discuss what they can expect post-transplant. And here's case 3. Mr. Carlson's a 68-year-old retired truck driver. He has a 40-pack-year smoking history. His wife died last year. He lives alone. He was diagnosed with Philadelphia chromosome-positive ALL last fall, and his induction course has been complicated. He had a fungal infection. He did not have a sibling match. He's preparing for a reduced intensity double umbilical cord blood transplant. And he comes alone to meet with you, discuss what he can expect post-transplant. So what parts of your discussion will these patients be the same? And what parts will differ? And why? So the objectives for learning during this session are to explain the risk factors for post-transplant complications and understand the unique components to each of 3 phases of post-transplant follow-up care. So as I mentioned, risk factors for post-transplant complications began pre-transplant. We're talking today primarily about post-transplant follow-up, but think about those patients that come to you. What about the 16-year-old soccer player who had mediastinal radiation and adriamycin as part of her Hodgkin's lymphoma? Primary therapy, pre-transplant comorbidities, the underlying diagnosis, all make need for you to start thinking as you meet with those patients and as you care for them throughout the rest of their lives and their families and their caregivers, what you can advise them and help prepare them for post-transplant follow-up care. So donor source, conditioning, whether or not that patient's getting an allo transplant, so y'all automatically have to start thinking about the problems associated with graft versus host disease, what infections, medications that are going to happen in the post-transplant period. Increasingly, we're understanding that genetic factors, polymorphism, may affect how they deal with different chemotherapies and drug levels and the toxicities and potentially the chance for cure. Their age, their gender, lifestyle factors. You worry when they come in and they've smoked for 40 years. So all of those things need to start going through your head. So as BMT providers, we think about 3 phases of transplant follow-up. The first phase, day 0, to typically around day 30, we're thinking about pre-engraftment, kind of peri-engraftment time frame. And then there's the post-engraftment, from day 30 to day 100 is in phase 2. And phase 3 is the late phase and beyond. And so that's what you're thinking about as a care provider. But do you know what about your patients are thinking of? They're thinking about, will they ever get off a roller coaster? There's going to be peaks, there's going to be valleys, and it's your job to help them get through all phases of this transplant. So phase 1, day 0 to day 30. Think about some pre-engraftment. Well, you have to start about that conditioning that would start at maybe at day -7. So just think, are you using radiation, carmustine, cytarabine, cyclophosphamide, topicide, fludarabine, melphalan, ATG? I mean, the list could go on. And it's really important for you as the care provider to understand the principal toxicities that are associated with each component of your conditioning regimen. So there are major organs that are affected. What about GVH prophylaxis in that allogeneic transplant recipient? If you automatically got to be thinking that you're using a calcineurin inhibitor, what is the risk of renal toxicity that you just heard about this morning? Methotrexate, commonly used. All the sirolimus, a variety of organs that are going to be affected. So you have to start thinking about the conditioning regimen and graft versus host disease prophylactic medications. In terms of toxicities early on, keep a couple things really in mind. Epithelial injury is one of the first things that we see. I'm going to just spend a minute talking about mucositis, but also, as you know, that central lines are a very large component, and epithelial injury increases the risk for infections. And then early on, I bet many of you have seen these rashes and you don't quite know what they are, right? And they haven't engrafted yet, and you're dealing with those all the time. So I'll just show you a few pictures of that. So mucositis usually begins about 5 to 10 days after initiation of chemotherapy and radiation. It lasts 1 to 2 weeks or until neutrophil recovery if you have delayed recovery. And, you know, often I think we talk with our patients before transplant that they might get mouth sores. How many of you have heard your patients say, well, I might get some mouth sores? They think, oh, a few mouth sores. But you all have seen bad mucositis, right? I mean, it hurts like here, down here, and all the way through your gut, right? Nausea, vomiting, diarrhea, you can't open your mouth, you're thinking about TPN, a whole variety of things that come along with that. A variety of drugs that can cause a variety of rashes, and some can be very severe. If you were looking at this, your differential diagnosis may be, my gosh, that patient has horrible graft versus host disease of the skin. You know, this is Stevens-Johnson syndrome, right, from a drug reaction. So those things are in our early time frame and really contribute then again to epithelial injury and risk of infection. We all know that pre-engraftment, that we're dealing with marrow toxicity, typically ablation in the reduced intensity regimens. Perhaps we won't have such a prolonged period of neutropenia that leads to infections. Anemia, fatigue, organ compromise, and thrombocytopenia that can lead to bleeding. And I just want to highlight a couple of things here. So opportunistic infections following transplant, we also think about them as phase 1, as pre-engraftment, phase 2, post-engraftment, and the late phase. And this is actually taken from a list that primarily is associated with allogeneic transplant recipients. It is also applicable, particularly in phase 1, to autologous transplant patients. So neutropenia, barrier breakdown, just as we talked about, mucositis, central venous access devices. The biggest infection problems that you're going to come across during that first phase of transplant, from gram-negative bacilli, gram-positive, and the GI. But there are also some viral infections that you're aware of in terms of using prophylactic antivirals, particularly the herpes virus infections, respiratory and enteric viruses, HHV6 that we just learned about. When I started transplanting, there was no HHV6 or 5 or 3 or whatever. I mean, as you go on into your career, you're going to have an increasingly number of infectious complications that I think that you will have a name for. Fungal infections can start occurring, as well as Candida and Aspergillus in the later portions of the pre-engraftment phase, and we'll come back to this a little bit later on, particularly for the allo patient. Bleeding, one of the things we're always watching for, we always think about, you know, the rare risk of bleeding in your head, GI bleeding, but one of the other things to be really cognizant of is diffuse alveolar hemorrhage in the early time frame. Again, many of us think it's related to cytokines, to epithelial damage, whether or not patient has prior pulmonary toxicity. And many of you are probably familiar with coming in. Maybe you're coming in at 6:30 to start seeing your patients on rounds, and someone's becoming really short of breath pretty suddenly, you know, to think about diffuse alveolar hemorrhage. You don't need a CT often to pick this up. and you'll probably have a real clear understanding even before you call pulmonary, thinking about BAL with increasingly bloody return. But this can come on quite suddenly for patients. Organ toxicity, I'm just going to highlight a couple. I know that you're going to be having some other talks, but I'll just mention a little bit about the other types of pulmonary complications and also liver complications in this early time frame. Pulmonary complications can be diverse. They can run from the pneumonias that we've just talked about with the risk factors of severity of mucositis and neutropenia, fungal infections, particularly whether or not they'd had fungal infections during their induction courses with therapy. So when you're admitting that patient and starting to follow them early, make sure you go back to that history of did they have any infectious complications. That may be even going into their local hospital with a neutropenic fever. Look through there. Was there a positive blood culture? Was there a C. diff? We know what those patients had coming in. Pulmonary edema. Cardiogenic pulmonary edema from all those fluids that you're giving them to help protect the kidneys, and pneumonitis and non-infectious. Remember we talked about pulmonary organ toxicity and whether or not the patients had radiation. The other organ I wanted to talk about briefly, although it's a fairly uncommon complication, is really bad and many people die, and this is hepatic sinusoidal obstruction syndrome. Maybe you've heard of the old terminology was veno-occlusive disease, or VOD. It's really rare, but affects both autologous and allogeneic transplant patients. Mortality is really high, and there really hasn't been anything identified that helps these patients other than supportive care. And we're starting to use defibrotide, which is off-label. I need to mention that. We think that some risk factors, pre-transplant, again, things to know about your patient, but also the conditioning regimen. Interestingly, we always thought it was kind of the recipient and kind of the recipient's problem, but I came across, as preparing for this talk, some evidence that perhaps there's something going on with the donor as well, that a single nucleotide polymorphism in an allogeneic donor has been implicated in pediatric recipients, and this is interleukin-1 beta. So keep in mind and watch out for genetic predispositions to toxicities as time goes by as well. We usually suspect it early on post-transplant. Usual onset's prior to day 20, but the peak is at day 12. The typical triad that you may be familiar with, weight gain, hepatomegaly, edema, and ascites, so the weight gains from fluid retention. And this just shows the histology of narrowing of the venules. The differential diagnosis includes medications, variety of infections, congestive heart failure, causing tender hepatomegaly, cholecystitis, cholestasis. And the major challenge is the lack of a sensitive diagnostic test, although we often get Dopplers. Usually by the time you see slowing or reversal flow, it's fairly late in the course. And again, really the mainstay remains supportive care. High-dose steroids have been used. Defibrotide is investigational. It's an antithrombotic, thrombolytic, anti-inflammatory, and anti-ischemic agent. So auto versus allo recipients. I asked you to think about what's the same and what's different when I started this talk. Well, what's the same? Pre-transplant therapies and comorbidities affect both auto and allo recipients. Conditioning toxicities may be similar. And the early infectious complications related to epithelial damage are similar. But what's different? Okay. Typically more rapid engraftment, median of 10 to 12 days, on autologous growth factor mobilized recipients. That leads to faster healing, fewer and more rapid resolution of infections. People start eating again, better sense of well-being and strength. Reduced intensity allo recipients may also benefit from early autologous recovery. But the allogeneic recipients are hanging out there a bit longer, right? They've got more medications to help prevent growth, graft versus host disease, and have that greater risk of infectious complications and organ toxicity. Well, let's move on to phase 2, all right? So typically we think of this as when engraftment is happening and for those first 100 days post-transplant. So there's also, I'm sure many of you are familiar with engraftment syndrome that we'll see in the autologous patients as they have rapid engraftment. Allo recipients is when we start thinking about acute graft versus host disease as they're engrafting. but note that there is a syndrome that has been recognized and defined as hyperacute graft versus host disease, which may occur before day 14. And then, of course, in our allo patients, the horrible complication that can occur of lasting engraftment. It's rare, but some auto patients will have very poor engraftment and remain transfusion dependent for some time, and that can certainly affect their quality of life. For unrelated donor umbilical cord blood recipients, may range from 5 to 10%. And that is a really tough complication to deal with. So that has to go as part of your pre-transplant counseling regarding phases of transplant care follow-up. Opportunistic infections in phase 2 are really affected by graft versus host disease, and that's when acute graft versus host disease is really coming along during this second phase of transplant. And then chronic may also begin during the second phase. Related to graft versus host disease, you can have impaired cellular and humoral immunity. NK cells recover first, and that's why there's so much work being done in NK cell immunotherapy. CD8 T cells are starting to increase, but it's still restricted T cell repertoire, as you've heard from your immune reconstitution. Gram-positive organisms start fading a little bit, particularly if you're starting to get catheters removed. In those auto patients, you're getting the catheters out, their mouths have healed, and there's less bacterial infections. Late viral infections that you need to think about during this time frame include cytomegalovirus. The respiratory enteric virus risk continues throughout all phases of transplant. EBV, or Epstein-Barr virus post-transplant lymphoproliferative disorder, you can see as early here as in the phase 2 of transplant follow-up in allogeneic recipients. And then fungal infections and the onset of the risk of cystic pneumonia begins in this phase as well. What about phase 3, the late phase and day 100 and beyond? That's when we have to start thinking about chronic graft versus host disease in the allo recipients. Late infections, again, the risk is higher if they've had active graft versus host disease, and as well as continued assessment for relapse. So let me tell you a little bit about what we think in terms of relapse for our patients and how often do we assess for relapse during this time frame. Typically, and I think the patterns vary a little bit by transplant center. At the University of Minnesota, we assess for engraftment, typically at day 21 to day 28. For autologous patients or allogeneics with lymphomas, that's when we'll start doing our scans. We rescan at day 100. And then after day 100, we'll typically do 1 year and 2 years and then stop. As you know, there's increasingly recognition that beyond 2 years of continued assessment, they may not be needed. And we typically won't do a bone marrow except at day 100 and 1 year and then 2 years and then stop as well. So how do you think about the risk of relapse for these patients and when they should be monitored? Well, the greatest risk for most diseases is in the first 2 years post-transplant. Relapse is higher for auto transplant recipients than allos, kind of a general rule, but then allo recipients have a higher rate of non-relapse mortality. So let's just take a look at this in terms of slides, and these are all available. I don't know if you know that, but on the CIBMTR on an annual basis, they update their slide sets. And so you can go in for all of the diseases and take a look at risk factors and get a sense of survival statistics for those patients. So for the 100-day mortality after an autologous transplant is pretty small. Let's just think about Ashley, your soccer player, that she has Hodgkin's disease and she's responding to salvage chemotherapy. She's chemosensitive. And so really for Hodgkin's lymphoma, or pretty much all the autologous patients, your risk of a treatment-related mortality by day 100 is pretty small. But what about her overall survival? Her risk of relapse is pretty significant, right? And when you think about this, if you look at years on the x-axis and probability of survival, that look within this first 1 year that the slope is steeper and then starts leveling out. So during that first 1 to 2 years post-transplant for Ashley is when you're going to be counseling her that her biggest risk of relapse is there. Well, what about our attorney with her 2 small kids? She wants to see those kids go to kindergarten, right? So what is the chance that she's going to die within those first 100 days and that the first and second phases of workup and transplant? Well, she had AML, if you'll remember, and she actually has early disease. You're going to take her to transplant in first remission, and her risk of transplant-related mortality is actually in 2010, this is the latest slides, is real small. You know, when I started transplanting, allogeneic transplants, had a risk more of 20 to 25%, and autologous patients had a risk of 10 to 15% of dying. So our supportive care measures have really improved. What about her chance of seeing those kids go to kindergarten? Okay, so look at the first year. So she has about a 30% mortality rate, 70% chance of being alive at 1 year, and continues to drop to about 50% over the next few years of seeing that age 1 make it to kindergarten. Well, what about our retired truck driver? He was going to have an unrelated transplant. Remember him? And he had ALO. We're also, this I think should explain to you that the earlier you make the decision to take a patient to transplant instead of waiting until later on in the course of the disease, the lower the risk of mortality. And so for early disease, again, it remains around 10%, but rises the further along advanced disease. Keep in mind, this does not take into account your patient in your clinic with those comorbidities, with those risk factors. Okay, so this is just all comers. And again, his biggest risk is of relapse. And again, the biggest risk is in the first 1 to 2 years. So if your patients can get out that far, the risk of relapse starts lessening. But here I think is a really nice summary slide in taking a look at the causes of death after transplants done in 2009 to 2010. And these are the summary slides that were available for 2012 released late last year. So for an let's look at autologous first. So I just mentioned to you that the biggest risk for Ashley, the soccer player, is not that she will die from a complication, right, during the first 100 days to a year, but her biggest risk is if she's going to relapse. Okay. So the chances, of course, are infection, organ failure, and we'll talk about second cancers, but the yellow portion is really worrisome. But I told you for allogeneic, the risk of relapsing is less. But take a look at the other reasons that patients will die. Graft versus host disease is a real problem, infections, organ failure, and even becomes more magnified in the unrelated setting. Opportunistic infections in phase 3 continue, particularly in those patients that have chronic graft versus host disease. Keep in mind about encapsulated bacteria for these allogeneic patients, and again, ongoing risk of viral and fungal infections. Vaccinations are incredibly important when you're thinking about the phases of transplant follow-up, and guidelines are available and easily accessible. But you have to explain that they'll have to start the baby shots all over again, right? And that comes as somewhat of a surprise to some of the patients, but also includes your autologous patients. And then increasingly, and I think it's been a bit of a theme at this conference, as the number of transplants rises and we've gotten better in supportive care, the number of survivors is increasing. And that's the fun part of our job, right? Seeing them come back. But there's a variety of late effects, and I will go through this relatively quickly because it was part of one of the plenary sessions the other morning. But I think what you really have to keep in mind, we think that patients that get through that first year are going to do all right. But take a look at this. Late effects cause long-term morbidity. And so this is really in the allogeneic setting of patients that had no graft versus host disease in the dark orange versus the resolved graft versus host disease versus active. And even at 11 to 28 years following transplant, even in those that had no graft versus host disease, 10% of patients still rated their health as fair or poor. And if they'd had graft versus host disease, resolved or active is a huge player in this. Over 30% of patients said their health was poor. This is interesting. If you take a look at the post-transplant after 2 years, this is autologous. And we think, well, gosh, with autologous patients, their counts come up, you know, they should go back to work, how are they doing? But look at this, that the patients still, in the autologous setting, many needed help for routine activities. Health prevented them from being actively engaged in school or work. I mean, I actually think she's going to go back to the soccer team and feel great that fall. Something you'll have to think about. How are you going to counsel her and her folks about that? And rated their health as fair or poor. So to go through a little bit of systems, I'm a very simple-minded physician, and I have to think from top to bottom. So ocular late effects, cataracts is a big one. It occurs even without total body irradiation, though we know that's a risk factor. 40 to 70% of patients that have total body irradiation will need to have cataract removal. Ocular Sicca syndrome is a really problem. Many of you have had patients with chronic graft versus host disease. Ischemic microvascular retinopathy, typically not seen post-auto transplant, is seen following allogeneic. And even posterior segment problems, hemorrhage, edema. And think about with all these late infections that they'll have throughout their course, particularly in allo patients with graft versus host disease, dental caries, gum retraction. So real problem for the patients. And then think about second cancers. Risk factors include graft versus host disease, whether or not they've had any head or neck radiation. Fanconi's anemia patients are very high risk for head and neck cancers. Pulmonary late effects are really diverse. Idiopathic pneumonia syndrome, also known as interstitial pneumonitis, can typically early post-transplant, as we mentioned in the beginning of the talk, but also can occur much at any time post-transplant. Is higher in allogeneic transplant recipients. Those have had TBI, graft versus host disease, immunologically compromised, and again, keep in mind, what did they have before transplant, what did they have during their conditioning? Bronchiolitis obliterans syndrome, I'll just mention briefly. I know that Paul Carpenter's going to be talking about graft versus host disease, and he'll go over this with you. But this is a major problem in chronic graft versus host disease. It's pretty rare, but leads to significant and very difficult quality of life for patients. Cardiac and vascular late effects was also highlighted a bit at this conference. A variety of cardiac dysfunction can occur, including cardiomyopathy, valvular anomalies, conduction anomalies, cerebrovascular disease, ischemic heart disease, peripheral arterial disease. Patients post-transplant in several studies have clearly been shown to be at greater risk of metabolic syndrome with hypertension, obesity, diabetes. We think that with longer follow-up that we're going to see an increasing number of patients have cardiac and vascular late effects. General population risk factors. Have they smoked? Is there hyperlipidemia? Their history of diabetes, steroids, secondary hyperglycemia from graft versus host disease. A variety of liver late effects. Medication toxicity associated with graft versus host disease, iron overload of all those transfusions that you gave patients coming into transplantation for MDS or during transplant. And always think about viral hepatitis. Both hepatitis B and hepatitis C are known to cause late problems. Skeletal late effects have been increasingly recognized and is actually being proposed as a multi-center trial through the BMT Clinical Trials Network in our survivorship group. Osteopenia occurs in up to 50% of patients, osteoporosis up to 25%, and the biggest loss is in the first 6 to 12 months. Steroids are a big problem with that, but we also know that calcineurin inhibitors Other immunosuppressive therapies contribute to this: hypogonadism, secondary hyperparathyroidism, and conditioning regimens. Avascular necrosis is a real issue for many patients. I have patients that have had both hips, both knees, and shoulders replaced. So it occurs in up to about 20% of survivors. Joint pain is the first clinical sign. Hip is most common. Plain x-rays aren't going to help you. You need an MRI scan, and therapy is a surgical approach. Endocrine-related effects. Hypothyroidism, recommendations to continue to check patients annually for life. Risk factors, TBI, mediastinal radiation. But other types of endocrine-related effects include autoimmune thyroiditis. Hypogonadism. Did you remember to think about that when you talked with Ashley? Or what about Mrs. Baker? Does she want another child? So that needs to come into your pre-transplant thinking. There's a low incidence of primary adrenal failure, and children a real issue in terms of growth. And depressive symptoms and psychological distress are frequent, both in patients, caregivers, spouses, and family members. I think one thing to keep in mind during this phase of post-transplant care, you would think that when patients are finally getting ready to leave your center, go back home, kind of resume care perhaps with their primary oncologist, that is the greatest risk time period for them. Have you ever said they're kind of scared to leave? That's really true. I once had a patient that it took him 2 days to get up the courage to actually leave his room and walk in the hallway because that had become the safe haven. Okay? Financial difficulties are a big issue. I have a patient that I followed for about 4 years, his chronic graft-versus-host disease, and the social worker showed me the form that he filled out saying what were his major concerns. And number 1 was paying the mortgage, and number 2 was food, and number 3 was paying for his medication. Secondary cancers increasingly recognize that we have more survivors. For allo recipients, it's a 2 to 3-fold increased risk of solid tumors. Epithelial type of solid tumors are some of the big ones, including lung cancer. Patients have had radiation therapy. We more frequently see sarcoma, breast, thyroid cancer. The risk continues to increase even after 10 years of transplant. For auto recipients, also keep in mind if they're coming in, we think, why do we keep checking their blood counts, for Hodgkin's lymphoma? Well, therapy-related AML and MDS has a median onset of about 2.5 years. Right before I came to TANDEM, I had a call from a doctor, and I have a patient who had an auto transplant a year ago who now has 200 neutrophils and a hemoglobin of 7 and a platelet count of 5. Solid tumors is, again, the greatest risk after for auto transplant for breast, thyroid, and again, PTLD, a post-transplant lymphoproliferative disorder, is rare, 1% at 10 years. Usually occurs by 6 months, but may be late. ATG is known to be a risk factor, as well as EBV. So the cumulative incidence continues to rise for solid tumors. It levels off for MDS and AML. PTLD is often earlier on. And I just would include some late effects references. If you were at Dr. Migel's talk the other morning about everything that's on the NMDP website, but there's also some other publications, particularly I think that are pertinent and helpful for late effects for children. So in summary, risk factors for transplant complications include pre-transplant comorbidities, primary therapy, age, gender, lifestyle, genetic factors, and post-transplant exposures. And there are unique components to each of the 3 phases of post-transplant follow-up. Keep in mind that in the first phase to think about epithelial injury and organ toxicity. Day 30 to 100, infections continue. Did the patient engraft? Have they developed graft-versus-host disease? Day 100 and beyond, relapse continues to be an issue. Chronic graft-versus-host disease, late toxicities, increasingly think about post-transplant long-term survivorship issues, not only for your patient, but for their family and support system. So let's come back to our 3 patients. What did you tell Ashley and her parents? Well, her risk of non-relapse mortality was pretty low, right? In many centers, it would be 1 to 2%. And you talk with them about the infections and the bleeding, the organ toxicity. But you have to explain to them from the very beginning that the dying from the transplant complication is the smallest issue, but the real concern is going to be, will she relapse? And hopefully you're going to be able to have some predictors to help you guide them in that discussion. And then what happens if she does relapse? That what alternative therapies would be available for her? They'll ask, can she have a second transplant? Those things come up. But what about late effects? Hopefully you address the issue of infertility with her. She's a young woman, she's 16. She's had mediastinal radiation. She's going to be at risk of hypothyroidism, cardiovascular disease, and increasingly we recognize that those women that have had mediastinal radiation are at increasingly risk after therapy for breast cancer. Well, what about Mrs. Baker? She has a significant risk of non-relapse mortality. She has a risk of infections. She has 2 little kids who come home with all kinds of viral infections. And you're going to need to go over that with her, as well as are those kids coming up for their live virus vaccines, and will they be able to visit mom in the hospital? Graft versus host disease will be a major discussion point for you. What if she relapses? She's having a sibling transplant, so you may be able to discuss with them that would be the possibility of donor lymphocyte infusion. And again, the discussion of late effects and second cancers. And what about your gentleman who has smoked for 40 years? He doesn't even have a support system, that he's going to have some friends come in and help him. His wife died. He lives alone. He's already under quite a bit of stress. Again, his risk is greatest of non-relapse mortality, and he's already had fungal infections during his induction therapy. So automatically you need to be thinking about that and making sure you explain to him that that is going to be a potential risk for him. He's going to have a double umbilical cord blood transplant. So as you're following him, you're already thinking, I got to make sure I discuss non-engraftment, and how's that going to affect how I follow this patient. What if he relapses? Well, you've used up your double cord, so there would be a different way of having to think about a second transplant or novel therapies. Late effects and second cancers, including his smoking history and lung. So with that, I want to close. I want to thank you for your attention, and we have a few minutes for some questions, and I'd be happy to entertain them. Thank you. Yeah.
Hi, thank you for the talk. It was excellent. My name is Kathy. I'm from Memorial Sloan Kettering in Manhattan. This was excellent. As clinicians, we all know all these wide variety of things that can happen to patients. My problem comes with informed consent. How do we give all this to the patients and their families before they come? They're so overwhelmed with numerous other things about coming for a transplant, how they're going to do that and manage that on a day-to-day level. I don't think they hear half of what we say and keep it inside, and then they afterward, all the frustration and the fear and everything else that comes out. Do you have a formal program for pre-education for patients and families where you are? Or how do you go about giving all of this to them before they come in so they really know and honestly can understand what's going to happen or potential that could happen to them?
So the question was, do we have a formal method of education for patients and their families? We just talked about all of these phases of transplant in about 40 minutes, and you've got all this knowledge in your head. How do you impart that with them? And it's a very scary time for them, right? So at our center we do. We have a patient would come for their new transplant appointment, and that typically is at least 2 hours. They meet with social worker, they meet with nurse coordinators, and they meet with us. And then as they come back for their workup, it's an entire week, and much of that includes education, not only for the patient, but also friends, family members, and that may be several hours. And then the transplant physician also, again, meets for another 2 hours. And then throughout, they have an assigned nurse coordinator and one designated transplant physician that will know them forever. But I think repetition, and every patient has a bone marrow transplant binder with all this information in there in lay language. But thank you for your question. It's incredibly important, and it's a scary time, and they'll often walk away after that first visit only remembering a little bit. Yes?
My name is Muhammad Lee from Sick Kids Toronto. The question is regarding idiopathic pneumonia syndrome, we know it has significant high mortality. Is there any infectious and non-infectious pneumonia or lung injury in a timely fashion? Because that way the treatment is different, like one is antimicrobial, the other one is profound immunosuppression with either high-dose corticosteroid or etanercept.
I'm not sure. Could you restate your question for me?
The question is, do we have any clinical tool to differentiate between IPS and like a non-infectious lung injury and an infectious lung injury? Because the time is crucial. If we start immunosuppression quickly, we might save.
So the question is, do we have diagnostic tools to help us determine between infectious pneumonitis and non-infectious causes of pneumonitis? Boy, do I wish. But I think we're getting there. You know, you're all familiar, of course, with thinking about the timing that it occurs, bronchoscopy testing, which is the sensitivity is much higher for bacterial and viral causes. For fungi, often we won't even, your stains and cultures will be negative. The galactomannan assays, even more sensitive ones for fungal, are coming along. There also are going to be new types of imaging, and maybe you saw some of that presentation earlier this week. Pulmonary and radiology physicians are developing new ways of looking at lung tissue by special scanning imaging that's going to be very helpful for determining fibrotic tissue, whether or not it is likely infectious, inflammatory, or whether or not it is BOS. And I think that's going to be incredibly helpful. Biomarkers are also starting to be looked at that may be very helpful in determining whether or not it's a potential infectious cause or non-infectious or BOS. So I think that even 3 years from now, it can be a different discussion. So things are on the horizon. Yeah.
Thank you very much for the talk. I have a question about the safety of Zostavax 2 years after transplant if no GVHD.
So I think you're speaking about live viral vaccines and how do we approach that?
Correct.
Yeah, and that also includes MMR, variety of ones. So that at our institution, at 2 years post-transplant, if a patient has been off immunosuppressive therapy, we will go ahead and use live virus vaccines. Many centers also use CD3 and CD19 and IgG levels as a time to not only begin vaccinations, but also then to consider live virus vaccinations.
And that includes Zostavax because it has higher, more viruses.
Yes. And I think it varies a little bit from institution. Hopefully we're standardizing more of care, particularly as guidelines are being developed, and Dr. Tomlin's manuscript that was published in BBMT a couple years ago trying to offer some guidance for this. Hopefully we're going to have even more medications to both prevent and treat infections that are coming along as well.
Thanks.
Thank you. Other questions? All right. Well, thank you very much. I appreciate your attention.